Good morning, my dear students. Today I will be discussing the last topic of the pharmacokinetics, that is excretion. But after discussing excretion, we will be shifted to the part elimination as a whole, and probably in the next video we will discuss half-life. So by the term excretion, we mean the passage out of systematically absorbed drug. Drugs and their metabolites are usually excreted in urine, and hence the term elimination, which is basically a combination of metabolism and excretion, is mentioned here in kidney. So, as it is primarily excreted via urine, so the kidney is probably the main excretory organ. Otherwise, there are some unabsorbed fractions where the drugs are present, and some drugs are there which are undergoing intrahepatic circulation. So, those drugs are excreted via stool. Such drugs like erythromycin, rifampicin, tetracycline, oral contraceptives, these are examples which are commonly excreted via stool. But most of the drugs are excreted via urine. There are some drugs which are also excreted via exhaled air. Gases and volatile liquids, the general anesthetics, the alcohols are eliminated by lungs. So, irrespective of their lipid solubility, they will be excreted. There are other method by which they have a minor importance for drug excretions, and those are saliva and sweat. So there are some drugs like lithium, potassium iodide, and some heavy metals. So these like arsenic, lead. So these are probably excreted via saliva and sweat. Lastly, the milk, which is very relevant because we know there is a physiological condition which is called lactation. Following pregnancy, most of the children are dependent on the milk from their mother, and the suckling infant unwantedly receives the drug. If the mother is getting the drug, the infant is also going to receive the drug because it is secreted via milk. So most drugs enter breast milk via passive diffusion, and more soluble and less protein bound drugs cross better. Milk has a pH of around 7. It is a lower pH than plasma. Plasma is having a pH of around 7.4, and therefore basic drugs are somewhat more concentrated in it. However, the total amount of the drug reaching the infant through breastfeeding is generally small, and majority of the drugs can be given to lactating mothers without usually having ill effects on the infant. There are some drugs we are specifying that these drugs are not safe, and hence you should not prescribe these drugs to the lactating woman. There are certain drugs which is already being mentioned in we'll discuss in the later part of general pharmacology, that those drugs are ideally not given in case of lactating women. But primarily, as I mentioned, the excretion is happened via kidney, and the kidney is responsible for excreting all water soluble substances. The amount of drug or its metabolites ultimately present in urine is basically the sum total of glomerular filtration, tubular reabsorption, and tubular secretion. So basically the net renal excretion equal to glomerular filtration plus tubular secretion, and it will be subtracted by or minus tubular reabsorption. So let us start with the first one, glomerular filtration. Glomerular capillaries have pores larger than usual, and all non-protein bound drug, whether lipid soluble or insoluble, presented in the glomerulus is filtered, and therefore glomerular filtration of a drug depends on the plasma protein binding and renal blood flow. Glomerular filtration rate which is normally around 120 milliliter per minute, declines progressively after the age of 50. So gradually we are having a decreased renal function, and therefore it is becoming further low in renal failure. So we have to selectively uh, selectively choose a drug so that it would not have a cumulative effect and have a toxic effect on human body, and especially in the elderly people and probably in those people who are having a problem of renal failure. The next part is tubular reabsorption. This occurs via passive diffusion and depends on the lipid solubility and ionization of the drug at the existing urinary pH. Now, lipid soluble drugs filtered at the glomerulus back diffuse in the tubules because 99% of glomerular filtrate is reabsorbed. But non-lipid soluble and highly ionized drugs are unable to do so. Thus, rate of excretion of such drugs like aminoglycoside antibiotics, there are some quaternary ammonium compounds which parallels this GFR, that means creatinine clearance. So, the changes in urinary pH, it affect tubular reabsorption of drugs, and they are partially ionized. Weak bases ionize more and are less reabsorbed because the urine is acidic. Weak acid will ionize more in alkaline urine, and hence it is usually less reabsorbed. So, if you want that your preparation is such that it's basically an acidic drug, you try to alkaline the urine so that it will ionize more and less reabsorbed, so it can be excreted via kidney. But it is again depending on the situation. If you want that drug to be present for longer duration of time in your plasma, so you require tubular reabsorption. So in that case, the urine should be in the acidic form, and the drug also prescribed ideally should be acidic, so that the reabsorption takes place more in quantity. This principle is utilized for facilitating elimination of the drug in case of poisoning. And urine, as I said, I am giving an example, is alkalinized in barbituric acid and salicylic acid poisoning. So from the concept I have given, you can understand why urine is alkalinized in case of acidic drug poisoning. Though elimination of weak bases like morphine, amphetamine, it can be enhanced by acidifying urine, and this is not usually practiced clinically. But the previous one which I mentioned, the acid poisoning, that means the salicylic acid poisoning and barbituric acid poisoning, the urine is alkalinized in the clinical practice. Why in case of alkaline drug it's not practiced clinically? Because acidosis can induce rhabdomyolysis, cardiotoxicity, actually worsen outcome. The effect of changes in urinary pH on drug excretion is greatest for those having pK value between 5 to 8, because only in their case pH dependent passive reabsorption is significant. The last but not least one is the tubular secretion. This is the active transfer of organic acids and bases by two separate classes of relatively non-specific transporter system. One is called OAT, that is organic acid transport system. The other one is called organic basic transport system, or abbreviated as OCT. They operate in the proximal tubules, and in addition to these two, the efflux transporters like P-glycoprotein, MRP2 are located in the luminal membrane of proximal tubular cells. Active transport of drug across tubules reduces concentration of its free form in the tubular vessels and promotes dissociation of protein-bound drug, and which then becomes available for secretion. Thus, protein binding, which is basically an hindrance for glomerular filtration of a drug, and is not so to excretion by tubular secretion. Now, what are the drugs which are undergoing organic acid transport? The acidic drug, the penicillin, probenecid, the normal component in our body, uric acid, the salicylic acid, the indomethacin, that means the painkiller, that is an analgesic, methotrexate. So these are undergoing organic acid transport. The drugs undergoing basic transports are amiloride, tramtarin, some kinds of thiazide like diuretic, quinine, choline, procainamide. So these kind of drugs. And both transport processes are bidirectional. They can transport their substances from blood to tubular fluid and vice versa. And therefore, for drugs and their metabolites, secretion into the tubular lumen usually predominates the show, whereas an endogenous substance like uric acid is predominantly reabsorbed. Drugs utilizing the same active transport compete with each other. Probenecid is an organic acid which has high affinity for the tubular organic acid transport. The active transport of both penicillin and uric acid is blocked by probenecid. So what happens? The net excretion of the penicillin is decreased, and therefore, and the latter obviously the uric acid is increased. Therefore, in a disease like gonorrhea, you may prescribe penicillin with that probenecid like drug, which is basically a transporter inhibitor, because the duration of action of penicillin is very short. So penicillin will be accumulated for a longer period of time in your plasma, and it is basically secreted. So the secretion is going to be stopped. While uric acid is primarily reabsorbed, and hence if the reabsorption is blocked, ideally this should be, uric acid should be excreted by urine. Hence the probenecid is going to be useful in gout. So one drug is basically showing two kinds of beneficial actions in two cases. With penicillin is doing one kind of thing, and with uric acid it is showing another kind of thing. The drug like aspirin blocks uricosuric action of probenecid and therefore decrease tubular secretion of one drug like methotrexate. Probenecid, as I said, decreases the concentration of increases the duration of action of penicillin and penicillin-like drug, impairs secretion of methotrexate-like drug. There is a drug like sulfenpyrazone which inhibits excretion of one drug which is basically used as anti-hyperglycemic drug, that is tolbutamide, or rather it's a hypoglycemic drug. And quinidine, which is basically an antiarrhythmic drug, decreases renal and biliary clearance of digoxin by inhibiting efflux carrier, that is P-glycoprotein. So tubular transport mechanisms are not well developed at birth, and hence the duration of action of many drugs like penicillin, cephalosporin, aspirin is longer in neonates. So accordingly you have to select the dose of the drug if something like septicemia, infection occurs in these patients. These systems mature during infancy. Renal function again progressively declines after the age of 50 years. Renal clearance of most of the drugs is very much lower in case of elderly patients where the age group is more than 75. So with this, I am concluding the part called excretion, and in my next post, in next video, we'll discuss the kinetics of elimination, zero order and first order kinetics, plasma half-life, preferably loading dose and maintenance dose, and steady state concentrations. So with that, I am concluding this part of excretion for the moment. Thank you so much.